So I did want to talk about, just kind of go through the highlights before we hand off to the Sunflower Foundation. Make sure that you're very clearly identifying um, how you're not, how you're working alongside, but nothing you do is going to get in the way or, supplant SNAP, WIC, other federal, state, and local food assistance. And we're going to talk a little bit about the rural transformation in a second, because I think it's going to be very important for those of you that are eligible entities under that, to talk a little bit about how what you do doesn't conflict with their work, and talk to KDHE about this, and we'll continue to work with them in getting information out to you that you may find useful in your application. So they are going to add some new UDS measures related to nutrition, and the way they're going to see if you're successful with this grant is the difference between your new 2027 data and your 2028 data, right? So they're going to just pull it out of your UDS. That's the reporting. They're really trying to simplify federal grants. Jim McCrae and others talked a lot about reducing things, and you'll see from this grant application how much they're kind of taking out of what we are used to. One of the great things about this application is you can spend 150,000 of the maximum 350,000 in year one for minor AR projects. So I know many of you may need space or may want to redo space to make it more useful for your food as medicine program, your nutrition programs, and this is a real opportunity for that. You can buy food. That's a big deal. You can do food prescriptions. You can, in year one, purchase a vehicle. You can do transportation. You can take people to the grocery store, to farms, to community education. So this is a real wide gamut of things that you can do that might enhance nutrition. And so I think there's a lot of opportunity for all of you. But there's a lot of limits. And I will tell you that what we're hearing, that the reason that the grant was kind of pulled back and now it's up as a forecasted grant, is that they're going to put even more sort of prohibitions in. So right now, make sure that, and these aren't things to really write in your grant, but I just want to tell you, as you're thinking through the grant and as you're writing the grant, be aware of these things, because these things are kind of the don't go there's when it comes to the work that you do. So this one, they're talking about racial preferences, the sex binary, illegal immigration, right? We know these are three of the administration's big priorities. So here are the application components. What you'll notice is there's no work plan, which I hate work plans, so makes me happy if I were writing it. No resolution of challenges. I will tell you, I've done most of the Bureau of Primary Healthcare grant reviews in the last 3 or 4 years now. And they'd already gotten to the point where we were instructed to not evaluate whether your challenges and resolutions were realistic. We just had to evaluate whether they were there. Did you have a challenge? Did you have a resolution? So they'd already been moving away from that. And so they've already pulled that all together out of this. So basically all you're really doing in the 50 pages is a narrative and a budget narrative. And then there are a few attachments, but those are just routine forms. You do have to do more if you're doing an AR project, any type of renovation, then you'll have to add equipment list, environmental information documentation, minor AR. Anybody that's done a federal grant that involves renovations knows all these. And so that's going to be more activities. None of those things count towards the 50-page limit, though. So I want to make sure everybody's aware that they always put the guidelines for reviewers, how the application is actually going to be reviewed, in the notice of funding opportunity. So these are the sections, 6 sections that equal 100 points. There are no, as far as I'm pretty positive, but it may come out different, there are no bonus points or no enhanced points. So when you talk about writing your needs section, they are going to ask you to put in UDS data, your quality of care measures, line 12, which is your, I believe that's the BMI for adults, but it may be the counseling for children. But line 12 and 13, you'll have to talk about the data that you have from your last UDS on that. You're able to put in additional quality care measures as appropriate, and I mistyped there, but I think one of the things that'll be important to talk about is how obviously hypertension and diabetes, but there's a lot of linkages to depression. We'll see from the work that Sunflower has done. So I think you could also talk about quality of care measures. And then I think it's important when you talk about your challenges with the current health center workforce, which we know is often a big issue, that you really talk about, well, what are you going to do? Like, we're going to write all these new positions in, is it CHWs, which are readily available? How are you going to get dietitians, things like that. So definitely talk about workforce challenges, but make sure you're clear how you plan to deal with those if you're putting that in your budget or planning to pay for those things. So if I were reviewing this application, which I won't be allowed to since I work here now, these are literally step by step what we would go to in the application. So if I were a reviewer for this application, I would read your needs section, and I would evaluate how well do they describe the need to start or expand nutrition services. What is the extent of data do they use? So if you are missing some of those UDS measures that are required, then I would have to take off points there. And then how strong is your description of challenges with workforce that impact your capacity to start? So big one to do there is talk about, we would do this tomorrow if we had the money, because, right, it's easy to answer that. Then you give me the money, I'll do this tomorrow. So those are the kinds of things I'd want to see as a reviewer there. So in the response section, one of the things to remember is the AR is in the first year of your award. They're going to ask for a 2-year budget justification. So make sure if you're spending $150,000 on AR or you're buying a car in the first year, that you're able to explain in your budget justification for year 2, what's that 150,000 or more that you're spending going to go into in year 2 and continuing years of the grant. Here's right. So after you answer these narrative questions, I would always then go through and say, did I answer each of these questions in this order clearly? So that, because the reviewers, they're instructed to find things wherever they can, but it is important, if you can, to make sure that you are, I would really clearly even use some of this language to make it easier to find. This is the part, the collaboration, I think we're going to have to talk about, and I'm going to help as much as I can to get information out of KDHE on their work with Food as Medicine. They'll be having their partner call tomorrow. But obviously, we'll write your letters from the PCA, from the Health Center Controlled Network. Certainly can help you get letters from any of the NTAP, SNAC, or anyone else that you think is going to be important to this. And then it aligns with and does not duplicate existing federal programs. And that's where a lot of this that's listed aren't going to be ones that you have in your service area or that you're interacting with. I would definitely point out that we don't have any of these if you don't have any of these in your service area. But I think it'll be important to talk about what's going on with Food as Medicine with the rural health transformation. Here are the collaboration measures. When it talks about impacts, right? So what are they going to do? The number of nutrition services, patients, or visits. As a reviewer, and I think most reviewers, there's no magic number for what this increase should look like. There's sometimes conversations when you say, hey, we need $1 million and we're going to add 30 patients. Sometimes in the review session, we'll have a conversation about, is that a good use of the funds? But, just try to make what you're planning to do realistic. I don't think you need to overstress, and definitely don't overpromise numbers, because remember, these are not going to be tracked in your UDS. So if you're overpromising numbers and you don't meet them, that could be an issue. So try to be realistic and then go probably a little under what you think is realistic. And, again, if you're going to add hypertension, diabetes, depression measures, I talk about some of those things under B. How is this going to help prevent and manage those chronic conditions that you're talking about from your UDS? Again, same measures, line 12 and 13. You can bring in some others as well. Use of screening tools or other risk identification screening. So those of you who prepare, in the past year, there is a question. In the past year, have you or any family member you live with been unable to get any of the following when it was really needed? And one of those choices is food. So you could use that measure from Prepare if you use Prepare. Another one that might matter for this, since we're talking about transportation, so there is a standard question about transportation as well. The other things that you could bring in when you talk about screening tools are weight assessments, clinical tools, clinical diagnoses. You can look at A1, gosh, A1Cs. Gosh, I can't talk today. And I know the Sunflower Foundation, Elizabeth, can talk about some of the data they have on health outcomes that might be things you would want to look at with this. Support requested. You can do a single minor alteration in year 1. You can buy food. Like I said, you want to really point out in year 2 changes from year 1. If you're doing things like doing a modification of your building, because that money is going to be freed up in year 2. Minor AR, you can see you can't do new construction. They expel what that is. You can only do it at one single in-scope service delivery site, so you can't do multiple modifications. It's got to be one place. And then just to kind of see where things are going and where I think when the application comes back up, these are things that are prioritized even in the application that was taken down at the beginning of last week. So gold standard science, program integrity and fiscal stewardship, which has always been there, partnership and local leadership, always been there, make America healthy again, child protections, biological integrity, parental rights and lawful use of funds, advancing evidence-based, merit-driven and ethically grounded healthcare. They will deprioritize organizations that do things like harm reduction, housing first, facilitated illegal drug use or unsafe medical practices, promote public safety, lawful use of federal funds, national health priorities. Here's some other stuff that they will, to the extent possible under law, not fund you if they prohibit open illicit drug use, urban camping and loitering, urban squatting, assisted outpatient treatment by moving them into treatment centers or other when they're unhoused, through civil commitment or other things. These are not things that I think are going to come up in your application, but just want to make sure this is kind of the first application under the Trump administration where some of this stuff is really going to come into account. And just like in your funding announcements, right, and in your contracts with the government, all this stuff is in there. All this stuff is going to be in grant applications from this point forward. The only other thing I would say before I hand off is, remember there's the HRSA webinar. We'll let you know if it gets moved or rescheduled again. And then for those who are interested, there is this partner coordination call of foods, medicine, and community health workers that KDHE has been invited to and that you are all welcome to come to. So I'm going to hand off to Elizabeth. Like I said, I was really pleased and excited by the data and information that I saw last fall and the work. We have such a head start on this application because of this work that the Sunflower Foundation has funded.
And thank you again, Robert, and the whole team at Community Care Network of Kansas for giving us a little time and space to highlight a few things that we learned. And let's go to the next slide, please. Just in full transparency, we are not going to launch into a full thing about food as medicine today. However, the slides that Robert mentioned from what we did in September, I'm happy to make sure Christy has those to send out to you in a PDF format after this so that you can pour through the data as much as you like. And we're also happy to bring some up during the discussion today. But what we really wanted to focus on, given that the name of this NOFO, when it does finally emerge again, is about expanding nutrition services, is to really pull out bits and pieces from the full-scale food as medicine program that the Kansas clinics did and really hone in on that. We just have up on the screen the different definitions of food as medicine. If you are going to incorporate that into your application, these are all the leading medical and scientific associations, Food and Society, the Aspen Institute, the Food as Medicine Coalition, Healthcare by Food with the American Heart Association, and the Food as Medicine Institute at Tufts University. Any or all of these would be wonderful resources for you to visit as you're thinking about your program, how you want to message it in your application, and bits and pieces that you might want to pull from it. Next slide, please. Just to you cannot do anything around food as medicine unless you show the infamous or famous pyramid. And what I wanted to point out on the side of this is with all the programs on the food as medicine pyramid, going down to even what perhaps is not part of technically food as medicine, but are more wide-scale nutrition security programs, nutrition counseling and education is key. And we are so excited to see that the feds are interested in paying for these services. As Sunflower, as a philanthropic funder, worked in this space, we kind of identified there's three ways we need to pay for a food as medicine program in this country. Obviously, the food, the CBOs, the community-based organizations that help procure, aggregate, distribute that food, and the activities that happen in a clinic around identifying, referring, setting up workflows, and most especially that one-on-one accountability, and education that happens with the clinic. So we really see this NOFO as a remarkable opportunity to get what you see on that right side of the slide, nutrition consulting and education, eventually paid for. Next slide. This is another great resource for you. The source of the paper is at the bottom, and we're happy to drop it into the chat box. But this is a model that really incorporates the different components of that nutrition and culinary education piece. So just one more thing to point you to. I also wanted to point out that, as you'll see from some of the later slides, most of the clinics in Kansas Food as Medicine Initiative did choose to do a lot of their, we'll call it nutrition education and behavior coaching in-house. That's not the only model. And this one even points to, there are other models where you can sort of benevolently outsource it to a third-party vendor. It might be could be a for-profit vendor, or it could be a local community-based CBO that's doing that work, or there might be some hybrid of the two. I did just want to point out, though, that we certainly learn from our KFME clinics, and I know some of you are on this call, and we expect you to speak up once I stop. The patients reported a very high satisfaction rate at being that connected to their clinical team, to the staff at the clinic, and the clinical staff also reported high rates of satisfaction of being able to finally meet a need that was persistent for so long. So just a little nugget that we did learn from KFME. Next slide. These are the clinics. These are the real stars of the show. Like I said, a few are on the call today, and I definitely hope they pop up. But these are true pioneers, and we are so grateful to federally qualified health clinics and CCNK for really establishing this work in Kansas. And as Robert said, getting the eyes of the country on our little square state in the middle of the country. Next slide. We wanted to show these baseline participant characteristics because this is what you might expect to see as you're designing and enrolling patients in any kind of nutrition education program. Clearly high rates of type 2 diabetes or prediabetes, and that was all the KFME clinics did choose that as their disease of focus. So no surprise there. You can see there the high rates of food insecurity. We did screen for that in the clinics, and I think I took out the slide with what all our screening tools, but we can pop it back in during the discussion point. This is where those partnerships with your CBOs and especially regional food pantries and, regional food banks and food pantries would be very helpful. The last thing, though, and what I really want to flag here on this slide is the high percentage, almost half, that screened positive for mild to moderate depression. And most of the KFME clinics had already been practicing some form of integrated care, so that behavioral health and primary care in the same setting. And we really see food as medicine as a natural extension of that whole person care. And really, if you are a clinic that is already practicing integrated care, you might be thinking about how whatever you do around food and nutrition might already build upon that work. In other words, they don't need to be two separate programs. Is there a chance they could build upon each other so you're getting some kind of layering effect for greater impact for the patients without also having to totally redesign a workflow for another project? I do want to flag here, those who screened for moderate to high severe depression did not fare as well in the program, at least with their clinical outcomes, if you looked at their A1Cs or their blood pressure. However, we did see some improvement in actually how they, in their self-reported mental health. So just something to keep in mind about the patient characteristics and who might do best in any kind of food or nutrition program. The other last two things is it's not on the slide. Those patients who were living alone, who were single, they did not do as well, which really speaks to the importance of peer support and accountability groups and thinking about those. And this is no surprise, patients who screened for having two or fewer missing appliances or two or more missing appliances, kitchen appliances, also didn't do well. No brainer, right? But it speaks to maybe would your patients, as part of a nutrition package, need some kind of welcome package that has basic kitchen utensils in it, like a cutting board or a knife, etc. Next slide. Last slide I'm going to do, I think, and then I'm going to hand it off to my far more experienced colleagues, Kelly and Carly, who are entrenched in the work every day. This is a very dense slide. And again, you'll get these over. But this really breaks down the food as medicine intervention in our 6K FEMI clinics. Again, I want to acknowledge that you may not choose to do a full-blown food as medicine program. And I would really respect that decision, because it is a lot to bite off, no pun intended. But hopefully there's bits and pieces that might guide whatever feasible plan, as Robert said, that you plan to do. 3 things to flag here. One is you'll see that only one clinic is listed here as having regular access to an RD. And even that was only for phase 1. There was another clinic that did have a little bit of contracted of RD time to overview meal plans, but they didn't do one-on-one with the patients. I mention this because with Mariana on the call, Sunflower has nothing but love and respect for our RDs, but they are rare and hard to find, especially in rural areas. So do not let the inability to find a full-time RD to enter your clinic as part of your program, please don't let that deter you from still applying for this NOFO. Mariana's, Dr. Wetherell's on the call today. We can bounce some ideas off of you about how to just use a sliver of an RD's brain for what you want to do, but don't think you have to have one full-time in order to do this work. It's about using them judiciously. The second thing I'll say is that you see SNAP-Ed. Yep, it was a very important part of the program for many clinics, and it's gone. But it doesn't mean those committed SNAP-Ed educators are gone from your community. I would wholeheartedly encourage you to call your county extension office, see if they still have their food and consumer sciences agent or their community health and wellness agent. They might be called different names. Just don't use the term SNAP-Ed. See if they have someone still on staff there or still engaged with that could be that community partner for your broad community nutrition education. And then the very last thing I'll say before tossing it over is you see the regional food banks were an instrumental partner for each and every clinic, and we'll talk just a little bit more about their important role next. And I think I am tossing it to Kelly and Carly at this point. Thank you, everyone.
Thanks, Elizabeth. I'll go ahead and jump in. So just wanted to provide a little bit more information about things we learned from our KFEMI partner, and specifically things we learned from the qualitative evaluation that was completed alongside the quantitative evaluation that Elizabeth alluded to in some of the previous slides, where we were capturing health outcomes like A1C. So Dr. Susan Harvey led our qualitative evaluation, and that represented, I think 10,000 miles plus driving around the state to make multiple visits to each clinic to do key informant interviews with clinics as well as their partners on multiple bases. And so want to flag a few things that we learned from those interviews in case they are helpful in shaping what your application looks like for this opportunity. So what we learned from clinic staff, there's a ton of rich information on this slide. You'll get this slide, but the one thing I wanted to highlight is that provider buy-in falls in both the challenge category and the success category. And I think what we initially heard from providers is that screening for making a nutrition referral, championing a nutrition referral can sometimes feel like one more thing that you don't have time for. That's certainly an initial sentiment that I think you could expect to be common. But what was important is that on subsequent visits, Dr. Harvey heard from those providers that they became the program's biggest champions. And what we heard is reasons why they transitioned from doubter to champion was often clinics taking the time to capture and then share back with their provider team data about the impact of that work. And so just wanted to emphasize the level setting, that there could be challenges here, and 2, the importance of sharing data internally with your team about the impact of these interventions, as that really seems to be the thing that got providers on board in championing food as medicine referrals at KFEMI clinics. Again, a lot of rich information here from interviews that Susan did with Food is Medicine participants at various stages in the outcome. And really the theme here is one that Elizabeth has already hit, and that is relationship, relationship, relationship. One, individuals participating in group cooking classes or group nutrition education courses found that highly valuable just from the um, accountability and support in being in a room with people going through similar health challenges. There's lots of documented benefits of that, but that's certainly something that we heard here. Another thing that I just wanted to provide some nuance around the relationship that Food is Medicine participants formed with clinic staff was highly valued. Um, we recognize that maybe that's not possible in every instance, and there might be ways to make additional services more accessible if they're provided virtually. But the specific challenge, just to have in the back of your mind as you're thinking about vendor-based options or tele-based options, is clinics specifically struggled with tele-based nutrition counseling options when the virtual coach or the virtual RD changed each time a patient visited. And so would encourage people to look for opportunities if you're going with a tele option to ensure that could still be a relationship-based experience and rather than a transactional one where the individual that a patient is speaking to might change each time they call in. Trust, I think, is an important part. Trust and relationship building is something that we heard is incredibly important for behavior change as complex as changing diet. Now I'm going to pause and turn it over to Kelly to talk about some of what we heard from food partners.
Awesome. Thanks, Carly. Well, what are we hearing from our community partners in nutrition interventions? We're hearing that they want to be involved. They care about the health of their communities, just like you all do. They find the Food is Medicine movement fascinating and impactful, and they want to be involved. I recently was presenting at a rural grocery store conference, and a grocery store came up to me and told me how jealous they were that their hospital was partnering with a different grocery store. They want to be involved. So I would say take a look at what's out there in your community, give them a call. I'm sure they would be happy to talk to you about different innovative ways that they could partner. And community partners increase your capacity. That's something important to talk about in your application, increasing that capacity. And community partnerships look great in applications too. And you can write about these community partners that you're going to reach out to that will help increase your capacity. Next slide, Carly. So I want to talk about one of the really important community partners that we worked with, and that's our food banks in Kansas. So we were very intentional about utilizing the charitable food system when sourcing food for this learning lab of clinics that we worked with. And we did that for really three main reasons. And the first was it was super cost effective. And that was really important in getting these pilot programs off the ground, that cost effectiveness. Second, our food banks' strength in distribution is really unmatched. They get food around our state. That is their job, and they're very good at it. They get food out to the most rural areas of our state, and that food arrives in fresh, delicious, ready-to-eat condition. The produce boxes that patients received, even out in our very rural areas, they loved them. That was one of their favorite parts. And third, we believe that working within the charitable food system really helps that health equity aspect of Food is Medicine. So you saw in that data slide that Elizabeth presented, it was 69% and 66% of those people that were enrolled in Food is Medicine enrolled Food Insecure. And so they're going to be in that intervention for 3 months or 6 months or 12 months, and then they're going to be done. And they really need to be able to access the same types of food that they were getting in that intervention, hopefully in their local community. And those local food pantries that are partners of our food banks make that possible. You know, there are some food pantries carry a lot of items that are great for a Food is Medicine intervention: canned tuna, canned chicken, dried beans, oatmeal, things that you can actually find in your food pantry can be used in your Food is Medicine interventions. All right, next slide. So this slide just shows a lot of different community partners that you can find for food as medicine interventions, nutrition interventions. They're varied, and I just want to point out a few that are really strong in the local food system. So of course, we talked about the charitable food system, always a great partner, but I also want to point out the local grocery store can be a super great partner. They can accept vouchers for patrons to purchase healthy food. They can provide those produce or shelf-stable boxes. They can provide community space for group classes or even advertising or putting certain, items that you may have in your recipes for your patients on sale. That can be a great partnership. Elizabeth talked a little bit about extension. Extension is a very important local partner. They often are super knowledgeable about the local food system. They can help make connections for you to the local food system. If they have a master gardener, that could be a super innovative partnership, teaching gardening classes for your participants or maybe starting a clinic garden. Local food pantries we talked about, local restaurants can be great, recipes, cooking demonstrations. Your local school district, if they're working on farm to school where they get those local foods and school meals, maybe you guys can share a farmer. Maybe you can, have an innovative partnership like that. And the last thing I think I'll talk about is correctional facilities. There's a couple great examples of correctional facilities in Kansas that are growing local food, providing that to the folks at their facilities, but also providing excess local food to food access points in their communities. So that can be a great partnership. And we think about leveraging these hyper local assets because one, it makes it easier for you guys, it increases your capacity, but two, we're not only thinking about community health, but we're also thinking about how we preserve and we expand our community wealth. And that's what working in those local community partnerships can do. Okay, I'm going to turn it back over to Carly, and she's going to finish us up, I think.
Okay, great. So what do you need in order to successfully implement nutrition education services? From the food as medicine work, here are some things that come to mind. As it relates to these technical assistance items, we're happy to be thought partners on any of those as you work through your application if that would be helpful. But also I wanted to refer to a few specific resources that Elizabeth alluded to before. Tufts has a Food as Medicine Institute, and they're putting out information on gold standard best practice every day. Aspen Institute Food and Society Group has 2 different editions of a Food as Medicine Research Action Plan that has a few tables that are really helpful for pairing kind of the nuts and bolts of what it looks like to implement these interventions according to best practice, as well as noting where there's gaps in that. And then I said Tufts, I said Aspen. The third one is American Heart Association's Healthcare by Food. They have an annual report that summarizes the state of randomized controlled trials related to this, and those could be helpful, like gold standard science practices to either cite in your application, as Robert alluded to that as a review criteria, or it could be really helpful pragmatic information as you think about program design and implementation. Specific things that we consistently heard from KFME partners, and these have both already come up, so I'll be super brief. Access to registered dietitian is extremely challenging. So I think we just have to make a plan to be as creative as possible about access there. And Dr. Mariana Wetherell, who is a registered dietitian and consults on the KFME project, is on the call today so that we can bounce ideas off of her about how we can make a registered dietitian's time go farther. Already alluded to, but really excited that there's allowable funds for renovation. Consistently, we heard from partners, particularly if you're working to store or distribute food from your location, space is a hot commodity, and being able to have the space that's going to accommodate that work is a real challenge. 2 things that I wanted to say as we think about what resources or assistance to potentially build into applications. We thought it might be helpful for you to know when we look back at our Food as Medicine grantee partners, staff time to deliver the services is far and away the most expensive element of this work. So if you're putting together a budget and you're wondering, is this on base? It checks out with our experience. If staff time is the kind of critical piece, most expensive element of delivering enhanced nutrition services. It's also been said, but just want to underscore it because I was shocked and excited when I saw it. It's really exciting that food appears to be an allowable cost in some circumstances in this initiative. So being able to have food for cooking demonstrations or cooking classes, or even it sounded to me like maybe produce prescriptions in some limited capacity could be allowable costs, and it just encouraging everyone to take advantage of that, as it's extremely rare to be able to find grant funds to cover that important aspect of this work. But we've just heard over and over again how valuable food is in bringing people together and building social connections, and just having the hands-on learning that is often necessary to make complex, challenging behavior change around diet. Elizabeth, I think I'll turn it over to you for last thoughts on tying this work into the Rural Health
Yep.
Transformation Program for Kansas.
Only thing I have to say here is it's happening. There's a call tomorrow. It sounds KDHE is very aware that this is happening. You're aware that that's happening. So ask your questions to them tomorrow about how they think perhaps these programs can be braided and blended.